Yeah, please continue though. You're on a roll there.
Well, I appreciate that. Like I said, I could keep rambling. So please, I guess careful what you ask for. I could
sit here listening all day, so don't worry. This is fascinating to me.
So early diagnostics is important, and so for many reasons. I think one of the most rewarding parts of doing this for that acutely brain injured patient is many times the answer will be, or the comment from them will be, "Wow, Dr. Mbeo, I was not imagining this. It's not. This was not just." These were not feelings that I was dreaming up. It's real. I can see it. And we're able to demonstrate, using objective measures. So that even for that a lot of gratitude from individuals who've been navigating a space where, up until now we've not been able to pinpoint. Why do they have these persistent headaches? Do they or do they not have these dizzy feelings that you can't really palpate? You can't put a scan on that. So it's real here. Thank you, Dr. Mbeo. I'm now I know. Even just knowing is good enough for me. Is what many people say. But the other part though becomes the benefit of early diagnostics is that we can initiate early therapeutics and we can impact things in the long run. Not everything. And I tell many of my patients, we can do the best we can to put all these pieces back together. And I will be ecstatic if we get you back to that 100%, if we get you back to you before the accident. But hey, I'll be happy. I'll be just as happy if we can get you back, better than the place that you are right now. And they say the same thing. Dr. Mbeo, if you said I was 100% before the accident, I'm at minus 10% now, and even getting me to 20%, I'll take that, Dr. Mbeo. And so early diagnostics, so taking an approach that has us, but really probing early for traumatic brain injury or for concussion symptoms, allows us to start interventions that'll impact or have been shown to impact outcomes further down the line. What do I mean? If we detect really profound balance dysfunction, so vestibular dysfunction, and this, in the post-concussion setting, in this post-traumatic brain injury setting, then one of the things that I usually tell my patients is let's once we're done with musculoskeletal rehab, because it'll be hard to do all these things with your back in severe pain or your shoulder, your knee in severe pain. Let's deal with that. And then now that we know that the next step will be to rehabilitate your balance, let's start to rehabilitate your balance either now or once you're done with musculoskeletal. So early rehab does have an impact on outcomes. And when you see patients who early on, let's say, miss that opportunity for diagnostics and they miss the opportunity for that early intervention, not unusual for them further down the line to still have these deficits. In fact, they might even compound because of just how bad things get with that missed diagnostic or missed chance to help. So early rehabilitation. So vestibular rehabilitation becomes one of those things. And there's many physical therapy facilities that have that distinction. They actually have the distinction of being able to offer care to that patient with post-concussion vestibulopathy or this dizziness and balance that just won't go away, and we can't really fix with medicines. Now it needs movement for that to be fixed. Helping with the cervical spine surprisingly actually helps a lot with the vestibular dysfunction, among other maneuvers. But early identification leads to early interventions, and that typically leads to better chance for a good outcome. So things of that nature. Areas such as visual and vestibular. So it's again these individuals who, as we do our visual vestibular ocular assessment, if we're able to pinpoint those deficits early, then again we're able to make moves to try and help with those visual vestibular dysfunctions, either through formal physical therapy directed at that, or through optometry or neurooptometry, or seeing a neuro-ophthalmologist or a neuro-optometrist, someone that's able to look at and maybe prescribe corrective lenses, for example, or prescribe courses of treatment to help with that, which ultimately will help with these profound dysfunctions they come in with. So early identification, early opportunity to treat. Headaches, my goodness, probably one of those common post-concussion complaints, these persistent headaches that just will not go away. And again, early identification gives us a chance for early intervention. In fact, sometimes something that low hanging that can have a profound impact on these post-traumatic headaches is good physical therapy, helping with the tight cervical paraspinal muscles, that really tense up after all this. Again, addressing that good physical therapy, can reduce the intensity of the headache. There's probably other things that we might resort to. So medications, following the same rules that we learn as we help patients with migraine. Interventions, so certain injections, nerve blocks, occipital nerve blocks, cryotherapy. So cryotherapy is one of the tools that has come handy. So cooling, almost like an ablation of the occipital nerve that has become really sensitive and is responsible for this misery that they're going through. So and Botox. In fact, Botox is one of those that many patients are finding benefit from, along with the therapies we've talked about. Cognitive, again, early identification of cognitive deficits through neurocognitive testing. Early identification gives us an opportunity to give them an opportunity to go through cognitive rehabilitation. At this point, actually, one of the easiest to miss consequences of concussion and traumatic brain injury is the psychiatry of it. So PTSD, heightened anxiety, depression that'll become heightened, trouble with focus, inattention, and things. So the psychiatry of it, and even more so in people that have underlying psychiatric conditions, then that even just throws them off into a place that spirals into a place that's really difficult to help with. But identity really helps with it, and there's many things we can do to help with all that. So it's again, early identification, and then it gives us a chance to put in place these measures early on. Perhaps on the PTSD side, and maybe in subsequent discussions, would be a good chance to talk about these novel approaches to help with let's talk psychiatry, the psychiatry of traumatic brain injury. So interventional procedures. So there's one that, as a neurointensivist in the intensive care unit and as an interventional pain management doctor, I became fascinated with the stellate ganglion block. So a sympathetic block of a ganglion that's in the neck. So that fight or flight ganglion that's in the neck area, and been known for decades, and decades ago was something that was used for cardiac abnormalities, cardiac arrhythmias. Medicine's not helping. Stellate ganglion was a go-to procedure. Then it disappeared and then made its re-emergence for many other reasons. But PTSD is actually one of the things that responds quite well to stellate ganglion. So again, ways we can use interventions with less medications. There's a role for medications, but interventions with less medication. So stellate ganglion block. So happy to talk more about that and just situations where in the brain injured patient, in a concussed patient, that could help, because many of these individuals, they've been through a traumatic exposure. And along with that is the consequences of this traumatic exposure, and then the need to keep re-exposing. Always need to get back in the car, need to drive many times right by the exact same place the accident happened, and then the consequences of that. So PTSD and heightened anxiety. So the psychiatry of it. So it's again quite important to assess it and then to address the psychiatry of traumatic brain injury. So again, early identification helps our patients, our clients tremendously further down the line.
Yeah, that's early identification. That's the name of the game from the minute you hit the door. Time is brain, right? And it doesn't sound like that changes. The further out you get, it may be a little longer of a process, but the earlier you get in. I love that reminder. I think one thing that that I think about, especially when you're talking about the psychology of it all, is the importance of family or the family social structure that's around a patient. Oftentimes these patients have a difficult time recognizing these things within themselves, right? Do you find yourself involving the family or loved ones or whoever the patient's social circle is in these discussions, in these interventions?
Absolutely. So it's important too, and I welcome the opportunity to. I'm ecstatic when I see family members, when I see friends, when I see loved ones, when I see work colleagues, roommates, and things like that. Again, because they know the before and they know what's happening right now. They know the after. They know the before. They know the after. They know more.
So important. So thank you for validating that. That is definitely crucial. So
it's reasonable to talk about some of the emerging therapeutic strategies that we can use in that concussed patient. One of the challenging parts of caring for patients with concussion or with the earlier spectrums, the earlier spectrum of a traumatic brain injury, and I intentionally use the earlier spectrum rather than the mild traumatic brain injury. That's the nomenclature we have right now, but nothing mild about the symptoms that many of these individuals have to live through for many years or for the rest of their life. But as we think through it, so one of the frustrations has been that we've gotten better and better at making diagnoses, but there's been a paucity as far as what can you do for many of these things. What can you do for my symptoms? In fact, as we have those conversations, as I have the approach that I tend to take tends to be, let's go for the low-hanging fruit. Even in these complex scenarios, let's go for the low-hanging fruit. And so let's talk headaches. So managing that very difficult headache, and headache tends to be one of those common consequences of a traumatic brain injury. And in some people, unfortunately, they become afflicted with this new transformation in what their headaches used to be. Now they go from a headache once in a while to daily headaches, so new daily persistent headaches, or they go from having no headaches to having really bad back of the head occipital neuralgia, or rather cranial neuralgia, so above the eye, so supratrochlear, supraorbital, so other really difficult to control. It's conventional medications may or may not play a role and may or may not help. Now, as I start to look at what else can we add, what are the new things that have shown benefit, we probably talked a little bit ago about cryoneurolysis, so cryoablation. So that's one of the tools that I'm quite excited about. So cryoablation. And what is that? We are simply using cold or cooling energy to make those nerves that have become really sensitive, where we're trying to inactivate those nerves using cooling energy. So cryoablation, very straightforward to administer. Whenever I start to hear suggestions of when I hear suggestions of cranial neuralgia, talk about supratrochlear, supraorbital, or occipital. The first step for me will be, let's try a nerve block. So let's try our conventional nerve. Let's start off by seeing, is that the nerve that's at play? And so conventional nerve block using a local anesthetic. Now, if that is successful, for me, that's been a marker for the utility of a cryo nerve block. So using one of many devices. There's one particular one that I've found utility, and I'm happy to talk about that in subsequent. But then a cryoablation device targeting those specific sensitized nerves, including the occipital nerve, including the auriculotemporal nerve, including the supratrochlear, supraorbital. And again, just by that, really impacting. We may not get them back to the 100% that they were before, but impacting the headaches with something novel such as nerve blocks. Tremendous impact to their quality of life. Botox, we talked about, again, Botox injections. And when we joke about it, when I tell my patients about it, they say, oh my gosh, doc, do you think of the traumatic brain injuries given me all those wrinkles? I say, well, no, we're not doing cosmetic Botox. We're using Botox in a slightly different way to reduce, these migraine-like headaches. So Botox every 3 months is how we administer it. And we typically target many of those. There's a protocol that has us target many of those areas that are affected when people have these refractory headaches. Transcranial magnetic stimulation, so TMS. So that's an area that I'm actually quite passionate about. And TMS has been available as a tool in the research world, I'd say since the 80s. It started to take a clinical role or to play a clinical role in the 2000s. And at present, quite a useful tool in helping with treatment-resistant depression. But that's not the only place. As the 2000s have gone by, as we keep keep looking at research that's available for the use of transcranial magnetic stimulation. There are studies showing the utility of electromagnetic stimulation using a special TMS machine to help with some of the consequences of traumatic brain injury, including the headaches, including the post-traumatic stress disorder, including the depression that many times overlays. So transcranial magnetic stimulation, a way we can use magnetic energy and not medications to help with many of the consequences of a traumatic brain injury. And the protocols vary, all the way from a 2-week protocol or 10 days. There's been research looking at a 10-day protocol for TMS in traumatic brain injury and some of the consequences of TBI. And then all the way to the conventional 30-something sessions that we use in treatment-resistant depression. But again, another way that we can use a novel tool to help these patients that have so few options. So TMS is something I'm quite passionate about. Other places that I see, perhaps maybe time will start to tell, and we'll start to see, the jury is still out on hyperbaric oxygen therapy, but certainly from a mechanistic standpoint, it shows promise. There's a lot of questions. Should we use true hyperbaric pressures? Right. Should we use the 3 atmospheres? Could they benefit from 2 atmospheres? Could they benefit from 1.5 atmospheres? Certainly, could they benefit from more pressurized oxygen or delivery of more pressurized oxygen than what we are ambiently receiving right now? Could there be benefit? So there's still patchy data, but I'd say anecdotally, I've had many of my patients that have seen a night and day difference. Okay. And so again, we'll see what time shows us as far as that as a novel therapy for these patients with so few options.
And these are these interventions, these therapies, these are all pretty minimally invasive, and these are things that you can do in your office?
Absolutely. And that's actually the goal. So as I look at them, yes. So things that are office offered, things available in some offices, maybe some not as available, but transcranial magnetic stimulation, certainly in my office right now, there's a click. If one listens carefully, you might hear a tap, and then that's the TMS machine that's going on in the brain spine pain institute. So TMS. So that's it's an office procedure, not invasive at all, tolerated by many people. Sessions taking about 30 minutes. Many people will take a nap through it, or they're nice and calm through it. And then there's many positives as they're going through it. But yeah, non-invasive, non-medication based therapy. As we talk about, let's say cryoablation or cryoneurolysis in office. In fact, the one particular probe that I've become really happy with, I carry in my pocket just like I carry my stethoscope, and then so it's in my lab coat depending on the situation. I don't walk around freezing people's heads and freezing people's cranial nerves. But then when the opportunity presents itself in the right patient with the right headache phenotype, a nerve block in the office, followed by a cryoablation procedure that's also able to be given in the office, taking a few minutes, not medication based, it's medication sparing, and then that can truly be situation altering. So another office procedure. Hyperbaric oxygen, so the true hyperbaric chambers in that medical grade, the 3 atmospheres, the kind of hyperbarics that divers would use for decompression, for the bends is what we call it. That is not available just cost and logistics of it becomes challenging to avail in offices. The lower atmosphere hyperbarics truly available or able to be accessed in conventional medical offices. Granted, it's not the kind of machine that let's say could be used in those other extremes of physiology, like the bends or in wound refractory wounds that are not healing, things like that, or carbon monoxide poisoning is not that type of machine. The other, lower atmosphere, truly available in offices. It can be available in offices. So becoming more accessible. So things that we can now start doing for our patients. So diagnose and then do. That's the theme in my mind. Diagnose and do, and that's what led to my navigation as a neurologist and then as an ICU neurologist, because I was really happy about being able to diagnose, but in the ICU, able to do. And then on the outpatient side, similar theme, diagnose and do something and try and make a difference in these individuals.
Yeah, that's key. I think, especially these days where you have so many specialized areas of medicine, being able to offer your patients the ability to not only be diagnosed, but treat and not have to go to different facilities or different towns or drive. So many people, as you mentioned earlier, have difficulty driving, just don't have the tolerance level to spend the time it may take to treat. So having those options right there and available is got to be key toward, having a successful treatment regimen. So thank you so much for enlightening us with that. I really would love to dig more into some of the nuts and bolts of some of those treatments. And it sounds like maybe we'll have the opportunity to do that in the future. I sure hope.
Certainly. So I welcome that opportunity. Let me know when, and I'm happy to jump on.
This has been fantastic. Thank you so much. Well, everybody, that's going to do it for another episode of Mind Matters, Navigating Head Injuries and Concussions. Dr. Mbeo, thank you so much for coming by and spending time with us and lending us your expert knowledge. Remember, everybody, to please hit like and subscribe and to hit that notification bell for our latest content. And as always, please remember, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.